and this is just an easy, informal discussion. If you have questions and I know the answer, I'll answer them. If I don't, ask it anyway, because that's going to make me curious, and we'll find out together. And then we'll both know more than we did. If you got stories you think are interesting, share them. Any comments? If you can't hear me or anything, don't hesitate to let me know. There's no test. The only test I will say is when you walk out, if you feel like you understand it a little bit better, then give yourself an A. Okay? So this is just easy, us getting together. And I want to share with you a little personal philosophy. Now, you don't have to subscribe to this. It's just the way I look at things. But there's an enormous amount to know. And what the good Lord knows about human anatomy and physiology, it's just infinite. I mean, we will never hope to know that. It reminds me of walking out on a starry night and looking up at the thousands of twinkling stars. And at some point, probably when you were younger, you tried to count them, and you would count until you realized that was going to be impossible. I mean, you cannot know what God knows, and there's an infinite amount to know. But having said that, you probably did recognize constellations. You probably know the Big Dipper and the Little Dipper, and maybe Orion, Orion's belt, the North Star. So you recognize things, you know things, and you can always learn more and increase your knowledge. Now, by doing so, you get better patient care. And that's what it's all about. That's the bottom line. It is about better patient care, better patient outcomes. But having more knowledge and advancing your knowledge will make your job easier. Your energy will be better spent on making good interventions and decisions, and not wasting your time on anxiety and worry and doubt and poor interventions. So it's really a win-win situation. It's worth the effort to invest in what you're doing right now. When you think about cardiology, this is one way to think about it. The heart is central to all the other systems. If the ticker is not ticking right, nothing else works good. So you just might as well go ahead and think about it as central. And the heart really is composed of 4 systems. I mean, there's a lot of verbiage that could be added to that, but it's a pump. It's a muscle, the muscular portion of it. What does the contraction, what pumps the blood. Diseases like heart failure and cardiomyopathy are a direct result primarily of pump dysfunction. The valves, of course, we see patients who have bad valves and have palpitations because of that, and shortness of breath, and have valve surgery, and undergo postoperative care. And the valves are one of the 4 parts of the heart. The plumbing, or the coronary flow, the blood going through the coronary artery supplying blood to the muscle, that's a big part of cardiology. I mean, there's a lot of money and energy and time spent and medical and nursing care delivered in the care for patients with coronary artery disease, getting them open, bypass, stents, so forth. And then last but not least, the management of rhythms, the management of the electrical system. And that's what we're concerned with today, and what y'all do an awful lot of here. Now, rhythms, suffice it to say, can be challenging. I mean, there are a lot of arrhythmias. There are a lot of different dysrhythmias, a lot of lethal rhythms, and it's a lot to them. And that's why we have EP to help sort those out. To understand abnormal rhythms, you have to understand normal. You cannot differentiate between abnormal if you do not know normal. Knowing normal, I hope to help give you a foundation to build on and a grasp to work from. To look at rhythms, the gold standard for rhythm analysis is not the heart monitor, it's not the echo, it's not the EP. First basic way to manage and look at rhythms is 12-lead EKG. Okay? That is the gold standard and the foundation of rhythm management. A lot of times what's on the monitor will not be on the 12-lead. The 12-lead is a way to get a comprehensive look at the rhythm and clarify it. Everybody with me so far? Okay. I want to take you back in time a little bit. I want to set a little bit of history. In the beginning, God created the heaven and the earth. That's as good a place to start as anywhere else. And man proceeded from there. Now, as we get into this, it's really not an official in-service unless we have some kind of snack or food. I'm going to ask our helper to get started passing these around. Okay. As man advanced through time, it was noted about 340 BC by Aristotle, one of the Greek philosophers, that there was a fish in the Mediterranean Ocean that shocked its prey. This fish, Torpedophanes, also known as the electric fish, could generate voltages of 8 to 220 volts, and that's a lot of volts, 220. And so ancient man recognized that there was a relationship between life and electricity. And it was demonstrated in this fish. If you've never seen one, there he is. There went a period of poor progression in science called the Dark Ages, and then there was the Renaissance. The Renaissance, I want you to think, remember, these are castles in Europe, and men and emerging scientists are dissecting and studying anatomy and struggling to understand physiology. And there were some important people, and I'm going to mention two of them. One of them was a guy called Voltaire. Voltaire invented something that is very useful to us today. He took copper disc, and he took paper saturated with sulfuric acid, and he took zinc disc, and he stacked them on top of one another, up and up and up and up, and he made something called a voltaic pile. Has anybody ever heard of that? It's a battery. He invented the battery. And as he invented the battery, people began to experiment with electricity. Then there came a very famous man named Luigi Galvanini, and he was from Bologna, Italy. And I'm not making that up. It's no baloney. That's where it's from. And in the little picture here, you'll see some frog legs in the bottom. And what happened, he was experimenting with electricity, and he'd been dissecting some frogs, and something happened, but some electricity hit the nerves on those frog legs, and they jumped and twitched. And it was like dead frog legs reanimated. And he discovered a relationship between life and electricity through these frog legs. It's a very, very important discovery. And also he did something else. He picked up something and created a galvanometer named after him. It detects electrical current. It basically detects electrical current. But it wasn't until 1903 when a gentleman named Wilhelm Einthoven made a galvanometer so sensitive that it could detect the electrical currents in the human heartbeat. The gentleman, the very austere and distinguished gentleman that Darrell has pointed out earlier, is Wilhelm Einthoven. He won the Nobel Peace Prize Nobel Prize in Medicine in 1924 because he invented the first EKG machine. This weird-looking little contraption to his left is the original string galvanometer that was sensitive enough to detect the human currents in a heartbeat. And it was the essential part of the first EKG machine. EKG machines, and I want you to turn after the written part to this page here. Okay, that's what the EKG machines, when the first commercially available EKG machine looked like. All right, those are buckets of saline, salt water, that the patient has his right arm, and left foot in. So they have progressed from that right there to a portable or roll-around cart that we see today. They have evolved and become a standard of rhythm management. And actually, if you want to know the truth, we build those out, CPT code 93,000, and the reimbursement, we charge $60 for an interpretation. We get $18 from Medicare. Now, you will not get a better bargain. An EKG interpretation for $18. That gives a lot of information about heart rhythm, rate, cardiac diseases, other pathologies. It's very useful, inexpensive. What's the risk of an EKG? Nothing. You might get a rash from the patch, but I mean, as things go, this is a very useful, very safe, very good test. In ACLS, if somebody's in asystole, what's the next thing you do? Check it in another lead. Yeah, you got to have more than one lead. So 12 lead EKGs have a unique purpose. Okay, everybody with me so far? Any questions? Sucker's okay? Okay, we're doing good. The cameraman get sucker? Oh, he's good. Okay. Well, let's look then at, these are some basics, and there's one basic principle that you got to know. Then some of these principles that I'm pointing out to you, they don't go to the effort, it seems like, to clarify and bring out in some of the other EKG classes I've had along through the nursing lines. So there's a couple of points that I picked up along the way I think that are important that you know. I don't have to tell you this. Our function and regulation of our body is due to hormonal and nervous control. And the nervous system functions on minute and small and tiny minuscule electrical currents. Does it not? Right. In nature, electrical circuits have a positive and a negative. Your battery has a positive and a negative. It's just endogenous to nature. There's hot, cold, there's north, south, there's good, bad, there's positive and negative. So there is a positive and negative basis to electrical circuits. There's another fundamental concept that you need to know. The body is a volume conductor of electricity. Let me give you a learning aid. Okay. This is an extension cord with bare copper ends right here. Now let's just pretend for a moment that we plug this in. Would you touch it with your finger? Would you touch it with your toe? Touch it with your tongue? Why not? Knock piss out of us, wouldn't it? All right. Well, there is the principle. The body is a volume conductor of electricity. Whether you touch it with your toe, your tongue, or your finger, it's going to shock you all the way through, right? So the minuscule currents generated by the heart are conducted out to the skin and are detectable. And if you amplify them and put them on paper, you got an EKG. Does that make sense? Okay. Now, another thing you need to know is in the positive and negative poles, the way the EKG machine is set up, the positive pole records an impulse coming towards it as an upright deflection. Impulse comes toward the positive pole, the EKG machine makes an upright deflection. Here's how you can remember that. Let's say, for example, that we're nurses working in Methodist, and we decide to go for Tops. We're going to Tops for lunch. Union Avenue, 12 o'clock, and you stepping out there, and cars are coming like they do at lunchtime on Union Avenue. And you see cars coming towards you, what's going to happen to your eyebrows? They're going up, right? Right. As they go past you, then they'll come back down, right? So just like cars coming towards you on Union, an electrical impulse moving toward the positive electrode makes an upright deflection. All right. Everybody with me so far? Okay. Let's look at normal sinus rhythm. Now, here's where we begin to get a little activity. I want you to go, there's a pretty picture of a normal complex in here. I want you to skip it, and I want you to go to the page that looks like this right here. Okay? And we're going to talk about, first let's talk about what happens in normal sinus rhythm and what happens on the EKG, and then we're going to explore that a little bit. Now we're going to have to share these, but we're going to color this dude. If you will notice, there's a, the top QRS is taken to be lead 1. That's just a lead. And we're going to need green marker over on this side, and green marker here, and green marker here, and yellow marker here, and purple, and blue, and red. And y'all share those, okay? Will you help them? Will you help the adults share? Will you help us? Okay. All right. Blue, purple, yellow. All right. Located in the upper right portion of the right atrium is the sinoatrial node. The heart tissue is specialized and unlike any other tissue in the body. The sinoatrial node is a nervous tissue that has the capacity to perform automaticity. It can on its own independently create a voltage like that fish and discharge it, and create another one and discharge it, and you don't have to think about it. And you can't think about it and stop it. It's independent. It is on its own. It's not volitional. It's made to pace. It's the king pacemaker. And so that dude fires. What happens? Exactly. An electrical impulse is conducted through the atria, through intra-atrial nodal pathways. Color the SA node green, and a big green arrow to go down to the AV node. How are we doing on time? Okay. Yeah, because that impulse is conducted down. And you'll see that on lead 1, which the positive part of lead 1 is on the right hand, lead 1 sees that electrical impulse come over toward it and makes an upright deflection called a P wave. Okay? This impulse is conducted through the atria like you throw a rock in a pond. You know how that wave goes out from there, and it goes through the atria. There's a specialized conduction tissue in the heart that controls the way that wave flows. Having said that, as the wave gets to the AV node, the atrioventricular node, there's a slight delay built in. And the reason for that is as the atria contract, there has to be a little bit of time for the blood to move out of the atria into the ventricle. It takes a little bit of time. So before anything else happens, that blood is given time to move into the ventricle. And the purpose of the AV node, which is marked as B here, and you should color yellow, is to delay the electrical impulse. Now when that impulse is delayed, what happens on the EKG? Look up on lead 1. Nothing. It's just a straight baseline, right? And if there's the delay. Okay. Same is true if you were looking up from the foot. You would see nothing, just straight baseline. The next thing that happens, and there is the impulse travels out through the common bundle of His down the right and left bundle branches. Now, I know that you know there is a right and a left bundle branch in the septum. Did you know one of them conducts a little faster than the other one? Yes. The left one is bigger. When it first hits, and this is why there's a little Q wave, why there is a QRS. What makes the Q wave? I'll show you. As the electrical impulse hits the common bundle of His and then goes down the right and left bundle branches, easy for me to say, the left one conducts faster. It's bigger. It conducts 0.01 seconds faster, but it's just enough that the septum depolarizes from left to right. The impulse in the septum goes from left to right first. It doesn't go down at the same time. Because it goes from left to right, look at the EKG lead 1. The electrical impulse is moving away, right? It's moving away from the positive electrode, the left hand in lead 1. It's moving away, so it makes a negative deflection, a little Q wave. Great. After it's done that, it moves down toward the bundle branches, and it begins to depolarize this huge, massive ventricular walls. Moves toward the apex. The purple represents it moving toward the apex, and the net electrical force is moving toward the apex. It's moving down and to the left. And so you get a big purple arrow, and the positive electrodes in the left hand of lead 1 see this current coming toward them, and they write a big starting of R wave. One more thing happens, and then we wrap this up. The right ventricle doesn't have so much mass. It's really not large. Left ventricle is. It's thick, does most of the work. And as this impulse has traveled and depolarized most of the heart, it still has to get the final terminal portions of the left ventricle. And high up toward the top of the left ventricle, that final wall is reached by the impulse and depolarized. That gives the final portion of the upstroke of the R wave in lead 1. Gives a little bit of S wave in looking up from the foot, AVF, which causes a little, as it's moving away from the foot, the positive electrode in the foot sees this impulse moving away and records it as a negative deflection. And that is the reason for the shape of the QRS in leads 1 and AVF. And we'll talk more about those specific leads in just a moment. Did that make sense? The septum depolarizing from left to right gives a tiny little wave called the Q wave in some leads. And the terminal portion of the depolarization of the left ventricle, when it finally reaches the final port of the left ventricle, it's a little deflection moving away from the foot, and that gives a little S wave in electrodes that look from below. Okay. Now that we know what the basic rhythm looks like, what a normal depolarization should look like, and we know what it looks like in lead 1, we just looked at it, but that's not going to be enough leads. And I want to give you a learning example, okay? You might ask yourself, why 12 leads? Why couldn't it just be 3? I mean, why does it have to be 12? Why couldn't it be 4? You know. And here's the answer. This is one of the oldest analogies that I know of in teaching this. There's something in this box, and there's some holes in the box. Here's one. Here's one. Look in this box and see if you can tell me what's in there. If you can't make it past somebody, maybe she can. See if you can tell me what's in there. That's got something to do with it. How about you? You see? You see what's in there? You can look in the hole on top. Okay. Here it goes. You want to try? Are y'all done? All right. This is one of the oldest analogies that I know. In the box. Is a tumor? No. So the saying goes, if you just have 1 or 2 views, you might not even be able to see something big as an elephant. Elephant in the box. So why 12 leads on EKG? Because 1 or 2 is not enough. With 1 or 2 views, you might not even be able to see something big as an elephant. Okay. So Mr. Einthoven thought about this when he was doing EKG, and he created something called Einthoven's triangle. Has anybody ever heard of that? You ever heard of Einthoven's triangle? Well, it's time we did. Would you like a learning aid? Might as well, huh? All right, so the guy with the old EKG had his left foot in a bucket of salt water and his right hand in a bucket of salt water and his left hand in a bucket of salt water. Now, they didn't have little sticky patches back when. Salt water conducts electricity very well, so Einthoven thought, well, if I put one here and I put one here and I put one here, I can make some views. And so he made something called Einthoven's triangle. Where is my heart? Is it within the triangle? Okay. So this just goes right straight across it, doesn't it? And then this kind of goes that way, and this one goes that way. All right. In your packet, there's a guy that looks like this right here. And this is it's Leonardo da Vinci's Vitruvian Man, and it has been artistically altered to serve our purposes, which means I use white out and a ballpoint pen to work on it. Now I want you to draw a dot on dude's right hand and a dot on dude's left hand and a line across there. Put a plus symbol on dude's left hand. If you, yep, on dude's left. All right, so if you were to connect a positive electrode over here and the negative electrode over here, you'd have lead 1. First lead Einthoven invented. Put a mark on dude's left foot and connect it to his right hand and also one to his left hand. And you've drawn Einthoven's triangle. And put a positive symbol down at his foot. And you have drawn lead 2 and lead 3. That's 3 of the 12 leads. Okay, moving right along. Now let's kick it up a notch. There's a page that looks like this right here, which is again an artist's representation. If you took that triangle, let's say it's just matchsticks or toothpicks. Let's just say you took a triangle made like that, and you rearranged those toothpicks a little bit. You can make it look more like this, couldn't you? And actually, you can make it look like that. And if you got down to it, you can just make them cross one another in the center. And it's called a triangle reference system. This represents lead 1, 2, and 3 just arranged around a central point. In the back, there's another page that looks like this right here. Now, if you were to take the electrode on the right hand and the one on the left hand and just connect them together, and then the one on the foot, you'd create a lead that just looks straight up, right? I mean, it's just going straight up and down. So on our little diagram here, what we've done is we have taken opportunity to connect the sides of this pyramid 2 at a time and create other leads. And when you connect in this way, you have to amplify it a little bit because it makes the impulse a little weaker. And so that's why on the 12 lead EKGs, these are called augmented A, voltage V, and it'll say F, that means from the foot, R, that means from the right, or L, that means from the left. And they create, if you at the bottom page you take Einthoven's triangle and you rearrange it, you get this thing called B. It's a triaxial reference system. If you reconnect the leads and make other angles with them, like as in C, you put all them together, you get something called the hexaaxial reference system. And all that means is you've got 6 views looking at the heart in this direction. Does that make sense? So you've got 6 views. Remember, 1 or 2 won't do. But you got 6 now. All you had to do was make 3 connections and you get 6. You get 6 views of the limb leads. Looking all through this direction, you can see good. You can see real good. Okay? The other thing, we need a view this way. To get 3 dimensions, you got to have more than just the one plane. So, going back to our sheet that's got the little triangles and the men, if you were to take some more electrodes and just start wrapping them around the chest, you'd create what's called the precordial leads, those leads that go around the cordium. And if you notice, V1, which is right here, is almost opposite V6, which is right here. Does this make me look fat on camera? Anyway, so they're just almost opposite. So you get the limb leads like this, and you get the V leads like this. You got a 3-dimensional look at the electrical system of the heart. 12 lead EKG. Does that make sense? It adds up, doesn't it? All right, now one more thing. I want you. We have to do this. You just got to do this. This drives the point home. How do I know? Why is that important? Well, people have different diseases in different parts of the heart, and we want to see all the parts. This is a model of the heart, and the bottom part of it is colored blue. The right coronary artery supplies the bottom part of the heart. If you were to go in here and pinch off that right coronary artery, it caused the bottom part of this heart to infarct. That'd be an inferior MI. I want the leads that look at the bottom part of the heart. I want to see what's happening with the bottom part of the heart. And they're on the 12 lead. I'm going to point them out. This, the heart sits in the chest basically like this. And this is the front part of the heart. It's supplied by the LAD, left anterior descending. If I was to go in there and pinch it off, or a bad plaque were to get in there, it would infarct the front of the heart, the anterior portion of the heart. The V leads would be good to look at that, and the ones over here. We'll talk more about that. And the left main bifurcates into the left anterior descending, which goes down the front of the heart, and the left circumflex, which goes to the side and the back. If I were to pinch off the circumflex, I were to pinch it right there, I'd infarct the side, lateral MI. So I want you to pass that around because, and see why I'm pointing that out, because that's exactly what the 12-lead EKG does. It divides that heart's electrical activity into family of leads. And what we're going to do is we're going to dissect one. Let's see. We may have to dissect the one in your packet. Thought I had brought some extras. Let's see. Yeah, I did. Here we go. Okay. The one in your packet you can keep because who knows, you might need it to do another class sometime. So this is the same EKG, the same person. And here's one that we're going to dissect. Did y'all dissect in school, in biology? Y'all cut frogs up and that kind of stuff? Yeah. Here you go, Mike. All right. All right. Now, I got a cautionary note in here. First thing is the computer interpretation on EKG up at the top about 50% of the time is not correct. At least 50% of the time those get amended. Do not get fooled into looking at that computer interpretation and thinking you know what's going on in that EKG. They're not right. Don't bet your career and a patient's life on that computer interpretation. Get somebody to look at it who knows, and you start looking at it because you can know. Just as we can learn more constellations, we can learn more about these EKGs. So, first thing we're going to do is we're going to fix that. Here y'all go. Here we go. So, let's break this boy down. Take your EKG and cut that top part off. Just cut that off. You don't need it. It's got the patient's name. We should know that. It's got a computer interpretation that may or may not be right. It's got some interval measurements that we can do ourselves. That thing's, that may or may not help you. Just throw that away. All right, it's looking better. Is it looking better already? Okay, it's not quite as much to interpret now, is it? All right. Down at the bottom, there is just a constant lead 2 running. This is a rhythm strip that the 12 lead provides. It just gives you a constant, if you need a little extra room to count the rate or look at the flutter or whatever, you don't need it. Cut it off. Just cut that boy off. Now, all right. We're learning now. Now, which is more intimidating, this or this? All right, all right. All right, now let's go one more. Fold it in half. Okay. Now we can kind of work with it. As a matter of fact, I'm going to do you one better. This top lead right here that is called AVR, which is augmented voltage from the right, which means there's a positive electrode connected here and the other two electrodes are connected together. This is a worthless lead. It does very little for you. Very limited application. Cut that boy out. Get rid of that. We're working on it now, ain't we?
Just
all right.
AVR, right?
Yep, just cut out AVR. Now we got 11 lead EKG. Now this is more of the way to look at them. When you look at the EKGs, begin to think about a family of leads. What looks at a particular area of the heart? On our diagrams, when we were looking at these leads, you'll see that lead 1 is a positive electrode, and over here it's going to look at the side of the heart. It's like you on Union Avenue and cars coming at you here. If it's over here on the left hand and the electrical impulse is coming this way, it's going to make an upright deflection, right? Okay. Don't do anything to it for right now. Lead 2, and by the way, these are listed in Roman numerals. Roman numeral 1, Roman numeral 2, Roman numeral 3. The reason for that is that's the way Einthoven named them, and medicine honors tradition. So they kept them that way. Lead 2 is on the left foot. It's looking up. It's looking up at the bottom of the heart, right? It's looking up. Any electrical impulse that comes toward it is going to write an upright deflection on EKG. Color lead 2 blue. And what we're shooting for, I think I showed you. We're shooting for something to look like this. Yeah. Lead 3 also is really right arm and the left foot again, and it looks up too. It looks up at the bottom of the heart. So it sees the bottom of the heart, which we're going to think about as being blue. Lead 2, blue. Lead 3, blue. And when we do that adding together, when we connect the right and left arm and have a positive pole at the left foot, and it looks straight up, that's called augmented voltage from the foot, it looks at the bottom of the heart. So look over on the same page, right over from lead 3 is AVF. Color that boy blue. Those are all leads that look at the bottom of the heart. If somebody's having an inferior MI, you would look at 2, 3, and AVF.
And MI?
Mm-hmm. If you were looking at any particular disease pattern, MI is a big one. I mean, you wanted to look at what's going on in the inferior wall, you would look at 2, 3, and AVF.
And that's the inferior?
Mm-hmm. Yeah, it's the bottom. It's looking at this bottom part, the inferior wall. All right, so those leads are look at the inferior wall. So that's what you need to know, to look at the inferior wall. Now, what about the lateral wall? Catches a lot of damage. I mean, the left system gets occluded and the left circumflex can clot up and things can happen to the lateral wall. Lead 1, one of the first leads we did, the positive pole is over here and it's looking at the side of the heart. Color it orange. Lead 1. Color it orange. Do I? Yeah. Did I cheat you? Yeah. And AVR we didn't count, we threw away because it really doesn't have much purpose for us, to be honest with you. But AVF does. I'm sorry, AVL does. It looks also at the lateral wall of the heart with the positive electrode being combined over here. Color it orange. That should take care of half of the EKG that you have right now. The front part should be colored, right? So flip it over to the other side. The precordial leads, which wrap around the chest, and they're looking this way. They're looking at the front and the sides of the heart. The ones that are all the way over here, B5 and B6, they look at the side of the heart too. You can color those orange. Those are the family of leads that look at the lateral wall of the heart. Okay? Now, V1, V2, V3, and V4 primarily look at the anterior wall of the heart, the front. And a lot of times the left anterior descending artery will be compromised and there will be an infarct in the front. It's called an anterior MI. Color the rest of those highlighted yellow. Those are the family of leads that look at the anterior wall of the heart. And that is a shot at explaining the 12 leads, why we have them, what they look at. Now, you need to know normal. You need to know what would look normal on here. I have you a recipe for normal. This will not, it's not perfect, but it's as simple and good as I can get, and I use it all the time. And the last page of your notes is the recipe, or the formula for a normal 12 lead. The first thing to be normal, there's only one normal rhythm. What's the only normal rhythm? Right. Everything else is sinus arrhythmia or sinus brady or beta. Everything else is abnormal. And there's two kinds of arrhythmias, right? Good ones, those that cause no problem, and bad ones, those that cause problems. But the only normal one is normal sinus rhythm. For a 12 lead to be normal, the rhythm has to be normal sinus rhythm. It has to look like we diagrammed it out. It has to be normal P wave, normal PR intervals, QRS, shape. It has to be a normal sinus rhythm. The other thing is you look for a current of injury. You look for ST segment elevation or depression, and that will be a different, perhaps, talk. That we're looking at normal right now. But if we were to look for MI patterns, we would look for ST segment elevation or depression. So there cannot be any of that. There has to be the absence of ischemic or injury patterns. And finally, some of these waves, you know, P waves sometimes are upright, sometimes they're negative. T waves upright and negative. What leads should they be upright in? What leads should they be negative in? What leads does it not matter? Well, here's the formula. You should have upright P waves and upright T waves in leads 1, 2, 3, AV 4, 5, and 6. I'm sorry, I said that wrong. Let me correct that. You should have upright P's and T's in lead 1 and in lead 2 and in the V leads 3, 4, 5, and 6. I have a typo on here where it says upright P's and T's in 1, 2 and Roman numeral 3. Make that say V3. Negative P waves, negative T waves, and any other leads, it doesn't matter. But these have to be upright. Upright P waves and T waves in 1 and 2, V, 3, 4, 5, and 6. And that, in a nutshell, is the basic history, development of the EKG, and what the normal conduction pathway is, what it should look like, and why we have 12 leads in the family of leads.